Good evening, everyone. Let us begin today's session with Omkaram. Om. Om. Now, let us follow it with NMO mantram. Natvaham kamahe rajyam, na swargam na punarbhavam, kamahe dukkha taptanam, praninamurti nashanam. A warm and heartfelt welcome to all the participants and respected faculty to the NMO AP's Med-Katalyst Foundation Program for first year medical students. Today, it is our privilege to have Dr. Vijaylakshmi ma'am from Department of Biochemistry. We sincerely thank you, ma'am, for graciously accepting our invitation. With great respect, I now request ma'am to kindly take over the session and guide us with her valuable insights. Thank you, ma'am.
Thank you very much. So today we'll just have a brief revision. So what I thought I will do is mostly concentrate on case-based scenarios in these topics which I am showing in front of you. Enzyme kinetics, inhibition, porphyrias, heme degradation, jaundice, acid-base disorders, because there is some confusion always for students, and on amino acid metabolism, very important points in amino acid metabolism. Okay, so let's begin. And before that, really, it's a nice endeavor by the NMOs and by these student volunteers who are taking a lot of interest and activating the NMO group. And I hope it is of benefit to you all. This will be a brief thing, hoping that you have some idea about biochemistry and not leaving it to the last 1 week before the exam studying about it. Okay, so let's start. So this is a case, as you can see. A 40-year-old man is brought to the emergency department after consuming illicit alcoholic beverage at a local celebration. 12 hours later, he develops severe headache, blurred vision, nausea, vomiting, and difficulty in breathing. So then, the questions which I have put here is, which enzyme normally metabolizes methanol? So for this now, this you have to remember it as it is a part of competitive inhibition, which you might get this as a question, where they will also mention that this person had methanol poisoning. These are the side effects which are seen in methanol poisoning, etc. So the important questions which you might have to answer is, which enzyme normally metabolizes methanol? It will be alcohol dehydrogenase. Okay. Why is methanol dangerous? Because finally it is going to get converted into formic acid, which is going to be of great danger to the optic nerve. That is, a person can become blind because of that. Now, what is the role of ethanol, or the drug, new drug which is being used in that case is called fomepizole. So why do they give it? Because ethanol or this drug, both of them, they act as competitive inhibitors of the enzyme alcohol dehydrogenase. Because ethanol will be metabolized by this alcohol dehydrogenase into acetaldehyde and finally into acetic acid, which is not as harmful as formic acid, because acetic acid can get converted into acetyl-CoA. So that is why this is given, so that the metabolism of methanol is reduced. That is why this is done. And how do the above affect enzyme kinetics? So you know, as a competitive inhibitor, which we will look at in detail. So this is, the question can be like this also. So now when we look at this, now this is what in enzyme kinetics we see. So what do we see here? We can see that on the y-axis, we have the velocity. On the x-axis, we have the substrate concentration in millimoles per liter. And we all know that half the Vmax, or by 2, that is half the maximum velocity. It is actually the Km is half the substrate concentration is Km. So wherever you get Vmax by 2 and where it crosses this, that is actually the Km. So the Km is what then? Km is the substrate concentration at half the maximum velocity. So you can see here that as long as you keep on increasing the substrate concentration, you keep increasing it here, initially the velocity is linear. And after some time, you can see that it is almost like becoming flat. That is, there is no more change in the velocity. That means it has reached a maximum velocity. One thing that we must understand in this graph, which is called saturation kinetics, is it is very difficult for us to find out the Vmax of something in vitro or in vivo, because enzyme molecules will react, they finish their reaction, and then they become free of the substrate. So finding a Vmax is very difficult. So that is why this is what they have is called Lineweaver-Burke plot. Lineweaver-Burke plot is, it is a state where you take the reciprocals. That is one thing. So here what you can understand here is, so what is Km value or Michaelis constant is, it is a substrate concentration at half the maximum velocity. That is what you have to understand in this. Now we come to the next one. So then I said we draw a double reciprocal plot. Why do we do this? Because it is very difficult for us to find out the Vmax of an enzyme, because it is unreachable. Because you keep on adding more and more amount of the substrate, you will never reach the maximum velocity normally. So that is why it is better to take the reciprocal graph. So this is what is shown here, 1 by V. So you can see this formula here. So 1 by V is equal to Km by Vmax into 1 by S plus 1 by Vmax. So this is equal to that Y is equal to AX plus B equation, right? So that is something that you have to just keep in mind before we go to the next one. Now we have a common question, that is enzyme inhibition. So we know what are inhibitors, what is an enzyme inhibition, we know. Now in these two textbooks that you have, Vasudevan gives the classification differently, Satyanarayana gives the classification differently. In Satyanarayana, the classification that is given is reversible and irreversible inhibition. Whereas in Vasudevan, when we take it, so it was just given in this form: competitive inhibition, non-competitive, uncompetitive. These are the three types, and these three are coming under reversible inhibition. And there is now a new thing which has been added in the Satyanarayana textbook is mixed inhibition. And in mixed inhibition, a part of it is non-competitive inhibition. So whichever you choose to write, either this or that, it is okay, as long as it is from a standard textbook. Okay. So then we will look at the competitive inhibition that we were talking about. Now, the example that usually is given is, so for succinate dehydrogenase, succinate is actually the substrate, right? That is getting converted to fumarate. We know this reaction in the TCA cycle. But now what is happening is you have a competitive inhibitor called malonate. Now, the name itself is telling you, now you can look at the structure here. It competes for, along with substrate, it competes for the substrate binding site in this enzyme called succinate dehydrogenase, right? So it is competing with that. To compete with that, definitely it should look similar to it. That is why it is called a substrate analog. It is similar to that. So being similar to that, it will go and it will bind to the active site of the substrate binding site on the enzyme. So when it is binding with that, if you have more amount of the inhibitor, definitely it is going to prevent the substrate from binding. So this is something. But if you have more amount of the substrate, then you can say that it has a higher probability of going and binding to the enzyme. So now let us look at the kinetics. Now this is the one below is the saturation kinetics, which we all know. So what has happened here? So here you can see this is with the inhibitor, the red line, and the blue one is without the inhibitor. Now without the inhibitor, you can see this is following the normal Michaelis-Menten or saturation kinetics it follows. Now with the inhibitor, you can see that the Km has increased here. Now why has the Km increased? Because we said Km is what? Substrate concentration. It is a substrate concentration at half the maximum velocity, right? So now if you add more amount of substrate, then that is going to compete with the inhibitor to bind to the substrate binding site. So then what is happening here? The Km has increased because we have added more amount of the substrate. So when you add more substrate, therefore naturally the Km will definitely increase, because what is the definition of Km? Substrate concentration. So substrate concentration, we had to increase it if we want the reaction to proceed. So therefore the Km is high, but the Vmax remains the same. It does not change at all. So as it is, you will get the same Vmax provided you have put in more substrate. The same thing is shown in the reciprocal graph. So in the reciprocal, what can you see? You can see that the 1 by Vmax which is there, the 1 by Vmax is actually showing you, that is that is the intercept on the y-axis. It is the intercept on the y-axis is 1 by Vmax, and minus 1 by Km is the intercept on the x-axis. So you can see when you do the reciprocal graph that it is the same place. You can see that on the y-axis, the same place these two lines are cutting. That means here the maximum velocity remains the same. Whereas you can see that the Km has changed here. The Km has increased. Therefore, minus 1 by Km is, you can see this is the point of minus 1 by Km. So from this, what is the matter? What is the enzyme kinetics that you're supposed to know? You're supposed to know that in the presence of an inhibitor, a Km is increased when you are going to have a competitive inhibitor. But there is no change in the maximum velocity. Okay, so the question that can be given to you is an alcohol or ethanol, which acts as a competitive inhibitor whenever methanol is taken. Or they can give you many other examples, like you can see here, and you can write a few examples like this. The common example you can also give is dihydrofolate reductase. The substrate is dihydrofolate, but the inhibitors are aminopterin and imidopterin. Now, these two are inhibitors for what? We use it for cancer treatment. I know all of you all will remember succinate dehydrogenase and malonate. That is something all of you all will remember. Then you can also give the example of HMG-CoA reductase. That is the enzyme which comes in cholesterol synthesis. And you can see here HMG-CoA here is the substrate here. And the inhibitor here, competitive inhibitor, is statin, lower statin. Okay. You can also give the example of xanthine oxidase. Hypoxanthine is a substrate. Allopurinol is the inhibitor. So whatever you remember about that, you can write. So this is about competitive inhibition, where the inhibitor is a substrate analog. So that is one point that you have to remember. Remember that Km is increased, Vmax remains the same. Now let us look at another type of inhibition. Now, in this type of inhibition, we are talking about non-competitive inhibition, which is a part of mixed inhibition. Okay, non-competitive inhibition, you can see this is the enzyme, and you are having this red is the inhibitor. So this inhibitor can bind to a site other than the active site. It is binding to the enzyme. It also has the ability to bind to the enzyme substrate complex, as you can see here. So what is happening? Because it is binding to an allosteric site, it can bind either to the free enzyme or it can bind to the enzyme substrate complex, right? So that means what has happened here? The Km remains the same. But now if you have an inhibitor binding, naturally Vmax is going to be reduced. So that is what this is going to be. So that is what we can see here in the saturation kinetics graph. We can see that the Km remains the same in the presence of an inhibitor, in the absence of an inhibitor. Km remains the same because the inhibitor is binding to a site other than the active site, right? That is one. Second thing here that you can remember here is your reciprocal, double reciprocal graph also, minus 1 by Km remains the same. Whereas you can see that there is a change in the maximum velocity. The 1 by Vmax will definitely be higher. What is the reason for that? Because Vmax is low. Vmax is low, therefore 1 by Vmax is higher. So that you can understand by the Lineweaver Burke plot. This is the second one, second type of inhibition. Now, what are the examples? You can read the examples in the books. I just want to explain to you that this is what is non-competitive inhibition, right? Okay. Then just to show you the difference between competitive and non-competitive. Competitive, usually it acts at the active site. Non-competitive usually does not act at the active site. The structure of the inhibitor, this is a substrate analog, the competitive inhibitor. This is a reversible one. Non-competitive is usually irreversible. And the structure of the inhibitor, it is an unrelated molecule. You can see here that excess substrate, if you add, it was going to relieve the inhibition. That means the Vmax is going as usual, whereas there is no effect here. Km, you can see, is increased here. There is no change. Vmax, there is no change here, whereas it is decreased there. Significance, all your drugs which you prepare for treatment of different diseases, they are all can be explained. Their action is usually competitive inhibition, whereas it is only toxic things which are going to cause non-competitive inhibition, right? Okay. Now we have the third one. Third one is called the uncompetitive inhibition. In uncompetitive inhibition, we can see that both Km and Vmax are reduced. And the speciality is it will bind only with the enzyme substrate complex, never with the free enzyme. Okay, it doesn't have any affinity for the free enzyme. So then what about its kinetics? And why is it so that it is giving you this sort of, that is, it is reducing the Km, it is also reducing the Vmax. So how is that possible that it is reducing the Km? This is the reason for that is it's a simple equation that you have to remember. We know that enzyme plus substrate will give you an enzyme substrate complex, which is finally going to get converted into an enzyme and a product, right? Now here, to this enzyme substrate complex, when an inhibitor comes and binds, what is going to happen? So a lot of this enzyme substrate complex will bind to the inhibitor and come out of the equation, right? So now what was the equation? Enzyme plus substrate forms the enzyme substrate complex, which is going to get into an enzyme and a product. But this inhibitor is only having affinity for the enzyme substrate complex. So it will bind to that and pull the enzyme substrate complex out of this equation. So because of that, what is happening? More and more about enzyme will bind to the substrate and form the enzyme substrate complex, right? So when more and more is being bound, what does it mean? That means now the enzyme has a high affinity to the substrate. That is why more and more is getting bound. So that is the reason why Km you can see here is low. So you can see here that the Km is low and you are having the Vmax is also going to be low. So Vmax is low, Km is low. Because Vmax is low, 1 by Vmax you can see it is higher. Here this is without the inhibitor and this is with the inhibitor. And you can learn the examples. So at least I want you all to understand this part. In competitive inhibition, what is actually happening? It is a substrate analog. Non-competitive inhibition, it is binding to a site other than the substrate binding site. Generally, it is irreversible, because of which Km remains the same. Vmax has got reduced. When you come to uncompetitive inhibition, what is actually happening in uncompetitive? Both Km and Vmax both are reduced because this inhibitor will bind only to the enzyme substrate complex. Okay, so if you understand this, you have understood enzyme kinetics. Now let us look at another case now. This is related to porphyrias. I'm sure you will have an idea about this. A 24-year-old woman is brought to the emergency department. She is complaining of severe crampy abdominal pain that suddenly started 24 hours ago. She complains of nausea, vomiting, constipation, weakness in both the legs. 2 days before the onset of symptoms, she was started on anti-epileptic medication. She was also on a strict low-calorie diet to lose weight. Okay. So on examination, what did they find? Temperature is normal, pulse was slightly high, blood pressure was high, abdomen was soft, there was tenderness, but there is no rigidity of the abdomen, it's not tight. Okay. Neurological examination, mild weakness. Routine examination, they found complete blood count is normal. Serum amylase, I think you have an idea what is amylase. It is an enzyme which is produced not only by the saliva but also by the pancreas. So usually we check this whenever we have a doubt about pancreatitis. Is that the one causing abdominal pain? We have to rule it out. So that was also normal. Then they said anything in the abdomen has it to do with the liver. So liver function tests were normal. They did an ultrasound, that was also normal. But the patient's urine was pale when she passed it freshly, but became reddish brown after standing in sunlight for several hours. And urine testing shows markedly elevated delta amylinic acid and POR. This is usually what will be given. So looking at this, I'm sure you have an idea. It is something related to porphyrias, right? Okay. So now let us go into the questions. Now, what is porphyria? What is the committed step in heme synthesis? What is the rate limiting enzyme? Which vitamin is required by ALA synthase? Which porphyria is associated with photosensitivity? These are the things that you have to know. Why are barbiturates contraindicated in acute intermittent porphyria? What is the role of heme therapy? Why does glucose help in treatment? Which porphyria causes blistering skin lesions? Name one inherited and one acquired porphyria. Anything can come as a question. So now just let us look briefly at heme structure. So heme, as you can see, that this is a tetrapyrrole ring. So you can see 1, 2, 3, 4 pyrrole rings are there. And then this is attached to substituent groups. One is a methyl, vinyl, methyl, vinyl, methyl, propionyl, again propionyl and methyl. So here it is reverse, right? So MV, MV, MP. Here it should have been MP, but it has got reverse. That's why these are called the group 3 isomers, right? So now just to show you, your porphyrin 1, if it is a 1 isomer, all the 4 substituent groups will be symmetrical. Like you have acetyl propionyl, that will be same. When it comes to the isomer 3 types, then it will be, you can see in the last ring, you can see that you have a reversal of the substituent groups. Same thing you can see coproporphyrinogen. What is happening here? The acetyl group and the propionyl. So acetyl has lost its carbon dioxide and it has become a methyl. So a methyl, you have MP, the whole thing is symmetrical. When it comes to the third type of isomers, then you can see that it is the 4th pyrrole ring. You are having the substituent groups are reversed. Now, when we come to protoporphyrin 3, here the propionyls, 2 propionyls which were there, they also lose their carbon dioxide and they start becoming vinyl. So this is just a basic understanding of what it was. Now let us just try to understand this, because it is, if you understand this, you can answer all the questions related to porphyrias which are going to come from here. So we know that this synthesis of heme, where is it going to take place? It mainly takes place in the bone marrow and in the liver. Also to some extent in other tissues also, but mainly in the liver and bone marrow. This is what it is taking place in. And which cells in the bone marrow? You have the erythroblasts. So in that you are going to have a lot of this heme synthesis. Okay. So now what are the reactions generally for whether it is in the bone marrow, whether it is in the liver? What are the normal reactions that we have? So you can see that the first step here, glycine plus succinyl-CoA. Now this is happening in 2 compartments. One is in the mitochondria, one is in the cytosol. So you're having it in 2 different compartments. So in the mitochondria, what can you see? You see that glycine plus succinyl-CoA. We know this is the simplest amino acid. Now this point you have to remember, because important products derived from glycine, which comes in amino acid metabolism, you can write it is also required for heme synthesis. Now this is one short bit that you can understand, and you can also remember it as one of the short notes which you can get. So glycine plus succinyl-CoA in the presence of an enzyme called delta-aminolinolenic acid synthase. Okay. Now this synthase, you have synthase 1, synthase 2. Now synthase 1 is present in the liver cells. Synthase 2 is present in the erythroblasts. Okay. So, and for this reaction, it requires a vitamin. Please remember this vitamin, which is B6. Okay, pyridoxine or B6. And you're going to have the formation of delta-aminolinolenic acid. So this is taking place in the mitochondria. So first step, remember, committed step, rate limiting step, everything is this one only. So you're going to have this reaction where glycine plus succinyl-CoA, ALA synthase 1, that is in the liver, and ALA synthase 2 in the erythroblasts. In this reaction where ALA synthase 1 acts as a rate limiting or the committed step is only in the liver, right? So this is happening here. You're having the formation of delta-aminolinolenic acid. Now, delta-aminolinolenic acid, once it is produced, it will enter into the cytosol. Now, in the cytosol, 2 molecules of delta-aminolinolenic acid are going to get joined by dehydration, and you have one porphobilinogen which is formed. Now, this porphobilinogens, 4 of them will join, and with the help of an enzyme which is called porphobilinogen deaminase. Okay, when it will be acted upon by porphobilinogen deaminase, it is able to form a linear tetrapyrrole. Okay, porphobilinogen is only 1 tetrapyrrole, right? So now with the help of the 4 molecules of porphobilinogen and in the presence of porphobilinogen deaminase, we are going to get a linear tetrapyrrole. Now, once this linear tetrapyrrole, so you can see it in your books as HMB synthase, etc. Some names are given. Whichever name is easy for you to remember, I would recommend porphobilinogen deaminase because the precursor is also porphobilinogen. So it is easy to remember that. So porphobilinogen deaminase. Deaminase, so you can say 4 ammonia molecules have gone out. That is what you can see here, right? Now, the next enzyme which is there is called uroporphyrinogen 3 co-synthase. Now, what will this do? This will make that linear tetrapyrrole into a cyclical structure that you have seen. So once a cyclical structure is formed, what is that product called? Uroporphyrinogen 3. Next, you have decarboxylation happening. I told you in uroporphyrinogen 3, the groups are acetyl group is there, right? So AP, 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 it was continuously like that, right? Except for the last one, it was PM. So, so you are going to have AP, 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 last one was PA, right? So now here you're going to have the decarboxylation is happening. So uroporphyrinogen decarboxylase will act on uroporphyrinogen 3 and it is going to convert it into coproporphyrinogen. What does coproporphyrinogen have? It has a methyl group. So it is MP, MP, MP and PM. So decarboxylation has happened. So you can see now how many enzymes: ALA dehydratase, porphobilinogen deaminase, uroporphyrinogen 3 co-synthase, uroporphyrinogen decarboxylase. So all these are there. Where are they? They are in the cytosol. Now coproporphyrinogen 3 isomer belonging to the 3 series, it is now entering into the mitochondria. Okay. Now in the mitochondria, remember these enzymes are always oxidases. Because after this, you will have a lot of oxidases that you have to remember. So what is it? Coproporphyrinogen oxidase. It will convert coproporphyrinogen into protoporphyrinogen 3. What is the speciality of protoporphyrinogen? Here, that MP, which was there, the P is also decarboxylated. And what are you having instead of P? You're having V. V stands for vinyl group. So you have MV, MV, and then MPPM. This is how you're going to get it. And now this is going to get oxidized into protoporphyrin. Now protoporphyrinogen, what is the gen meaning? Gen means that you can have the bonds between the tetrapyrroles which were there. They were actually single bonds till now. Once it becomes a porphyrin, a double bond will start. So methylene bridges are becoming methinyl bridges. So once the double bond comes, then it starts absorbing light. So coproporphyrinogen does not absorb light. Coproporphyrin starts absorbing light. That is why it is able to give you a reddish color. Okay. So now what is the next one? The next thing here is now protoporphyrin 3 will accept the iron with the help of the enzyme called ferrochelatase and form heme. This is important because heme can inhibit ALA synthase. Okay, so heme can inhibit ALA synthase. So it is proper to have the final product which is actually going to act as a feedback inhibition to ALA synthase. That is the first step, which is also in the mitochondria. So you have to remember here, 4 steps are there in the mitochondria, 4 steps are there in the cytosol. The last step and the first step are definitely there in the mitochondria. And before that, you can see there are all oxidases which are there. The last step, because it is taking iron and putting it inside, that is why that is called ferrochelatase. It is chelating that iron. It is holding the iron and putting it into this protoporphyrin 3 so that you have the formation of heme. I hope this part of it is clear. If you have any doubts, we'll take it in the last. Okay, so any part which you haven't understood, we can just go through that. So then comes the question of, okay, this is the common questions which will be given to you, that is porphyrias. So write in detail about porphyrias. So you can classify them. First, define what is a porphyria. These are inherited disorders related to the heme synthesis. That is what you'll write. Then you will say that they can be divided into 2 groups. You can have congenital and acquired. In the congenital, you can draw this table. Okay. So acquired, remember only one. Don't have to remember so many things which have been given in your book. Just remember one, and that one is lead poisoning, because that is very important. So just remember lead poisoning, and you think of lead poisoning, then remember that it will inhibit. What does it inhibit? It inhibits one ferrochelatase, and the other one that it is going to inhibit will be your ALA dehydratase. It will be inhibiting these 2. Okay. Now, what are the enzymes here and the porphyrias? Remember, though they have written ALA synthase 2, ALA dehydratase, they are not exactly porphyrias because no porphyrins are produced here. But they have been included because they come in heme synthesis, so they have been included. So ALA synthase 2, I told you this is there in the erythroblasts. So it will cause anemia, sideroblastic anemia. ALA dehydratase deficiency if you have, then this is mainly hepatic, and you will have, what will happen in ALA dehydratase deficiency? The precursors. So what is the precursor in that? So you are having delta aminolevulinic acid. Now that can cause severe neuropsychiatric symptoms and abdominal pain. Okay, so this is about, and this is inhibited by what we said, it is inhibited by lead. Okay, and you have to remember that most of these are all autosomal dominant disorders. You have one autosomal recessive, and that autosomal recessive is congenital erythropoietic porphyria. So just remember that most of the porphyrias, so we are not talking about these two here, right? Most of the porphyrias which are having porphyrins in the urine are all autosomal dominant. What is the exception here? Autosomal recessive is congenital erythropoietic porphyria. Please remember that point. And you always have to remember that if you are having porphyrins in the urine, only porphyrins are there, or only porphyrins are there in the blood or in the urine, then usually we will have skin changes will be there, cutaneous manifestations will be there. If the precursors are there, like you're having delta aminolevulinic acid is there, or you are going to have the next product like porphobilinogen will be there, then you will have severe abdominal pain and neuropsychiatric symptoms. Now, the case that we have seen is for this enzyme, that is porphobilinogen deaminase. Okay, if this enzyme is deficient, then what will happen? Then you will have this, you're going to have what? You're going to have that linear tetrapyrrole, right? Linear tetrapyrrole. So that linear tetrapyrrole is present, and this linear tetrapyrrole is uroporphyrinogen 1 synthase if it is deficient, PBG deaminase if it is deficient, or HMB synthase if it is going to be deficient. You are not going to be able to form the uroporphyrinogen 3 is not being formed here. So in this case, what is going to happen? Acute intermittent porphyria will be seen. Acute intermittent porphyria, you are going to have abdominal pain, neuropsychiatric symptoms. What is the reason why these are there? Because it's only porphobilinogen which is there, right? So only porphobilinogen is going to be there, and porphobilinogen cannot do anything like any cutaneous manifestations because the porphyrins have not formed at all. So therefore, you will still have only abdominal pain, neuropsychiatric symptoms. And remember that this is not common. The most common is not this. So if they give you a question, write in detail about something which is the most common. Remember that it is a different porphyria and not this. This is an acute porphyria. It presents acutely. Okay. So if they say an acute porphyria which is common, then you can write about acute intermittent porphyria where you have a deficiency of PBG deaminase. This is what you can write. Then we have the next one, which is uroporphyrinogen 3 synthase. If 3 synthase is not there, then uroporphyrinogen 1 is still produced. The linear tetrapyrrole is there, uroporphyrinogen 1 is being produced. So it is being produced. So therefore, the person will have photosensitivity. So this is the first porphyrin which is being produced, and the person will have photosensitivity. Next, which is the most common one? Remember, it is deficiency of this enzyme, uroporphyrinogen decarboxylase. So when decarboxylase is absent, uroporphyrinogen 3 is high. This causes porphyria cutanea tarda, which is the most common one, and this causes photosensitivity. So that is what you can remember. Then you have coproporphyrinogen oxidase deficiency. It causes hereditary coproporphyria, and this causes photosensitivity, abdominal pain, neuropsychiatric symptoms. It causes not only cutaneous manifestations, neuropsychiatric also. Similarly, protoporphyrinogen oxidase, this is called variegate. So remember that name, variegate porphyria. Variegate means it shows two features: photosensitivity, abdominal pain, neuropsychiatric symptoms. This is C. And finally, you have ferrochelatase deficiency. Mainly it is erythropoietic. So you can also, in your textbooks, if you see, there are some which are only hepatic. There are some which are only the erythrocytic or the erythropoietic porphyrias, you can see. So you can divide it in that way, or you also have acute and chronic porphyrias. So from this, what you can remember here is, whenever you have ALA and PBG levels only mentioned, remember it cannot belong to any part where porphyrinogens have formed. It means it is a step before porphyrinogen formation. Once porphyrinogens are formed, then you are usually going to get cutaneous hypersensitivity. Whereas here we can see that there is also abdominal pain which is mentioned here. Okay. Whereas in this case, for what reason it is not clear, but in this case, PBG levels also are going to be so high that they can cause a problem. Okay. And in protoporphyrinogen oxidase also, you can see that PBG levels are high that they can cause a problem. And photosensitivity, anytime whenever you are having porphyrinogens, if they are there, definitely they will be photosensitive. That is what you have to remember from this. And if you look at Vasudevan, you will see this classification, acute and chronic. Acute means suddenly. So wherever you have abdominal pain, it will be sudden, it will be acute. So acute intermittent, hereditary coproporphyria, variegate porphyria. In chronic, you will have the other three. Congenital erythropoietic, which is mainly cutaneous, erythropoietic porphyria cutaneous, porphyria cutaneous tarda mixed. Sometimes it can be acute presentation, sometimes it can be a chronic presentation. So these are the features. Acute and chronic means, what I mean to say in this is, a person may be born with this congenital manifestation, but unless there is an external trigger, the porphyria will not manifest itself. That is why it is mentioned as mixed. So it will come under mixed. So I hope this is clear about porphyrias. Right? So you should remember one point here, that is, whenever you are going to have mainly porphyrins or porphyrinogens, then it will have a cutaneous manifestation. And those which are usually having ALA, PBG also mentioned, along with porphyrins which are being mentioned, then you always have to think about, it could be definitely acute episode is there, and the acute porphyrias, as you can see, are acute intermittent, hereditary coproporphyria, variegate porphyria. And usually the question will come on acute intermittent porphyria, or you can get a question on just most common. Then you'll have to think about porphyria cutaneous tarda. So this is what you can take from this information. Acquired, I have already told you. Lead poisoning, at least that one thing you remember. ALA dehydratase deficiency will come only when zinc, which is an inhibitor of that ALA dehydratase. I mean, because zinc is already there, so lead can act as an inhibitor for ALA dehydratase, because lead will inhibit the action of zinc. Similarly, ferrochelatase, iron is there, then again lead will inhibit the action of ferrochelatase. So two metals for this, right? So zinc and iron are inhibited by lead. So at least that one thing you please remember. Then we go into, so we have finished two topics now. One related to enzyme kinetics, the second one which is related to porphyrias. And as I told you, two questions which can come from there. Acute intermittent porphyria you can get, and then porphyria cutaneous tarda. Usually these are the two things. So be clear about them. Now, the next one we can go into is, a question can come like this related to jaundice. Why am I talking about that? Because it is heme degradation. So heme degradation gives you bilirubin. How do you, usually I see a confusion in students, bile pigments and bile salts. That is what I see a confusion. Remember, a pigment will come from another pigment. So bilirubin is a pigment. You know, it is a bile pigment. So it should come from a pigment. What is that pigment? Heme. So from heme, when you get something, and definitely it must be a pigment. Bile salts are being produced from cholesterol. Okay, that class you finished having that, so I hope you know that clearly. Let us look at this. So here you might get a question like this. What is this question about? So here you are having a 48-year-old man is presents with jaundice, dark urine, pale stools, generalized itching, elevated ALP. I hope the full forms you should be very clear. Alkaline phosphatase with predominantly conjugated hyperbilirubinemia. You might get a case like this. So they will ask you, classify the type of jaundice, draw the bilirubin metabolism pathway, indicate the site of pathology, explain the biochemical basis of dark urine but pale stools, and suggest 3 investigations to confirm the diagnosis. You should be able to explain. So now this case, when you look at it, now see jaundice, so you should be sure that it definitely bilirubin will be elevated. He's having dark urine. Now here, what have they given? Pale stools. So pale stools, if that word comes, remember it must be obstructive jaundice. So pale stools, if they say, there is no doubt that this is an obstructive jaundice. So what is the cause of obstructive jaundice? You can have either a tumor of the head of the pancreas, you can have stones in the gallbladder, or the common bile duct, you can have stones. Strictures or narrowing can be there. So in all these things, what is going to happen? You're going to have this conjugated bilirubin, which is produced in the liver, entering into the blood circulation. Once it enters the blood circulation, it will definitely be excreted in the urine. Therefore, the urine is dark. Why is the stool pale? This is the reason for this is this conjugated bilirubin, instead of entering into the intestine through the bile duct, it is not being allowed to enter the intestine. If it enters into the intestine, then it can be converted into sterco and urobilinogen. That is not happening. So because of that, the feces are pale. Next, why is there generalized itching here? You have to remember that when there is an obstruction, then what is happening? This conjugated bilirubin is now from the liver, it is able to enter into the blood. So when the levels of conjugated bilirubin are so high, it is going to affect the biliary canaliculi also. And on the biliary canalicular cells which are there, in that place, you also have plenty of alkaline phosphatase. So alkaline phosphatase enters into the blood. That is one. Second thing for itching, the reason is lot of bile salts which are there. Now they also, because of this obstruction, bile salts also, instead of entering into the intestine, they will enter into the blood. So when they enter into the blood, they are going to affect the nerve endings which are there. So they are, blood means they also enter the extracellular fluid. So they are going to affect the nerve endings, and that gives you a feeling of itching. So that is the reason why there is itching. And it is clearly mentioned here, predominantly conjugated hyperbilirubinemia. In some places, they might give you the values also. They give you the values of total bilirubin. They might give you the value of direct bilirubin. Direct bilirubin means conjugated bilirubin value they will give you. Always see whether the conjugated bilirubin value is extremely high when compared to the unconjugated bilirubin or the indirect bilirubin. If it is extremely high, then you know it must be a case of conjugated hyperbilirubinemia or obstructive jaundice. Okay. So, so then we will look at just the pathway. How is it that bilirubin is produced? Because that is also asked. So heme, remember, you don't have to draw this confusion. Don't have to take it so much in. Just remember that heme is being converted into biliverdin. So when heme is converted to biliverdin, what is the enzymes that you require? Heme oxygenase is what you require. Because it is heme oxygenase, it requires oxygen definitely, and it requires cytochrome C and ADPH. And it is only in this reaction that carbon monoxide is produced. Iron will be liberated. And you are now again getting back your linear tetrapyrrole ring. This is called biliverdin. Now this biliverdin is reduced to form bilirubin. Okay, so you can see here how it is reduced by biliverdin reductase. So this is, where is this happening? It is happening in the reticuloendothelial cells of the liver, spleen, and the bone marrow, right? Now, after all this is happening, now this unconjugated bilirubin which is being produced, it is taken to the liver by binding with albumin. So it binds to albumin because it cannot dissolve. I mean, it is not soluble in blood. So it has to be carried. With what is it carried? With albumin. So it is carried by albumin, goes to the liver. In the liver, it is going to be conjugated. With what is it conjugated? With glucuronic acid. So here you remember your detoxification chapter. So glucuronic acid is going to conjugate so many things to make it more water soluble so that it's easily excretable. So it is combining with glucuronic acid with the help of the enzyme called UDP glucuronyl transferase. That is the enzyme. And you're having the formation of bilirubin diglucuronide. Now this bilirubin diglucuronide is now able to enter through the bile duct. It enters into the small intestine. Now in the small intestine, from there, it gradually goes to the large intestine. In the large intestine, we know that there are bacteria. What do the bacteria do? They deconjugate it. Once they deconjugate it, bilirubin becomes free of this conjugation of glucuronic acid. On this free bilirubin, further the bacteria are going to act and convert them into sterco and urobilinogens. Now these, some of the sterco and urobilinogen, that they undergo enterohepatic circulation. So they undergo enterohepatic circulation, and as they undergo enterohepatic circulation, a small quantity will be excreted by the kidney. Because it is excreted by the kidney, we call it urobilinogen. And as soon as it's exposed to air, then it is going to get oxidized and it forms urobilin. And urobilinogen daily excretion, you can see it is less than 4 milligrams per day. Similarly, stercobilinogen is going to get excreted about 300 milligrams per day. So this is an overall picture. If you understand this, you can solve any question which they give on jaundice, whether it is conjugated, unconjugated, that is the hemolytic, hepatic, post-hepatic, anything you'll be able to answer. Now, differential diagnosis. How do you know that this is hemolytic, this is hepatocellular, this is obstructive? So you can see here, I'll just look at each one like this. Okay, hemolytic jaundice. Now the name hemolysis. So many of you all are confused into hemolytic anemia, hemolytic jaundice. Okay, so I say what is the cause of any jaundice? You will say hemolytic anemia. So one thing, surely hemolytic anemia or hemolysis will definitely can cause jaundice. There is no doubt in that. But be very clear that hemolytic jaundice might occur in infants also. In children also, you can see hemolytic jaundice. Okay, so try not to have too much of a confusion. One of the features of hemolytic anemia is jaundice. But when they are talking about hemolytic anemia, they want you to focus more on anemia. When they are talking about hemolytic jaundice, they want you to focus more on bilirubin here. So be clear in these two. Now coming to hemolytic jaundice. So in hemolytic jaundice, you can see that in the blood, the free bilirubin, means what they mean is unconjugated bilirubin, which is being carried by albumin, its level is going to be increased. Conjugated bilirubin may be normal. In the blood, alkaline phosphatase is normal. So remember, though I have written only alkaline phosphatase here, remember ALT, alanine transaminase, then you have aspartate transaminase, those are also normal here. Then in the urine, you can see that there will be no bile salts because there is no question of obstruction here, right? Then urine conjugated bilirubin is definitely not going to be there because there is no obstruction to the flow of bile. Then urine bilinogens are increased. How is it that bilinogens are increased? Because now so much of hemolysis is happening, so much of unconjugated bilirubin is being formed, so much of unconjugated bilirubin is entering into the liver. So imagine so much of conjugated bilirubin is being formed, so much of conjugated bilirubin has entered into the intestine and is being converted into plenty of these urobilinogen and stercobilinogen. So this urobilinogen is excreted in the urine and the feces. So feces are dark, urine is dark. That is because of the urobilinogen and the stercobilinogen. Now when you get, so hemolytic jaundice, usually they will talk about any case of hemolysis. They will talk about that. So the case scenario will be related to hemolysis. And one dead giveaway of hemolytic jaundice is, you can see that all the liver enzymes will be normal. So if liver enzymes are normal and they are saying unconjugated bilirubin is very high, you know it is hemolytic jaundice. Now when you come to hepatocellular jaundice, usually they will say some infection is there in that person. Okay, so viral hepatitis they might talk about, or they can say some medicines their person was using because of which liver is damaged, alcohol, they can talk about so many things. So hepatocellular jaundice. So what is happening in this? In this you can see a biphasic jaundice. That is both unconjugated bilirubin is increased, conjugated bilirubin is also increased. Why is it that conjugated bilirubin is increased? Is when the liver cells are affected, they become inflamed. Then the size of the hepatocyte is increasing. When it is increasing, what happens is one liver cell and the next cell, in between these two cells, you are having the canaliculi. When the cell is becoming inflamed, it is going to narrow. These two large hepatocytes will try to block the biliary canaliculi, which is going in between. So when they block that, what is going to happen? You will have the conjugated bilirubin which is being formed, instead of entering into the biliary canaliculi, will start entering into the blood, into the sinusoid which is just next to it. So it will enter that, and therefore you can see that this is also increased. Then urine bile salts. In urine bile salts, you can see that it is Like here, urine bile salts, it is not there initially in hemolytic. Here, it may not be there, but later on, when the obstruction becomes more, I said initially it will just block the biliary canaliculi. When suppose this obstruction has become severe, then you can see that bile salts will also be seen in the urine. Urine conjugate bilirubin may be present. Then urine bilinogens are less because some amount of obstruction is there, therefore they can be less. Fecal urobilinogen is definitely going to be decreased because of some amount of obstruction. Obstructive jaundice we spoke about here, and we said that free bilirubin is in obstructive jaundice, the free bilirubin may be normal. Okay, so even if they give a slight increase, don't worry, just look at the conjugate bilirubin. It is very much, then you are sure that okay, this must be a case of obstructive jaundice. In biphasic, that is hepatocellular, you'll see it is almost similar. The conjugated bilirubin might be 7, unconjugated bilirubin might be 4. So whatever it is, it will be close to one another. Whereas in obstructive, it will be significantly far from one another. So if the conjugated is 2, the conjugated is 10, the unconjugated might be 2. So it could be like that. And you can see the ALP levels are extremely high in obstructive jaundice. In hepatocellular jaundice, here you might have an increase of ALP, but look more at ALT and AST. ALT and AST are quite high. Then you know it is definitely hepatocellular jaundice. That means it will be in thousands, or it will even cross thousands. Okay? And ALP, alkaline phosphatase, if it is around 700 like that, then you are sure that it must be a case of obstructive jaundice. And conjugate bilirubin is there in the urine. Urine bilinogens are absent, because of which urine will not have the bilinogens, but the feces is pale because that mainly has stercobilinogen, which is not there now. So the feces will be pale. Why is the urine dark? Not because of the bilinogens. Urine is dark because conjugate bilirubin is being excreted. That is why the urine is dark. Then you can see fecal urobilinogen is absent. So this is how you divide that. So whenever the enzymes are very high, ALT, AST, be very sure it is a case of hepatocellular jaundice. Whenever ALP levels, which indicates obstructive jaundice, is very high, then you know it is a case of obstructive jaundice. All the enzymes are normal, you know it is hemolytic jaundice. Whenever you can see urine urobilinogen levels are extremely high, if they mention, you know it is a case of hemolytic jaundice. If they say pale stools, you know that it is a case of obstructive jaundice. So I hope this part is going to be clear, and you might get a case, any of this can become a case for you. And this is again something I think in physiology also it must be done. It must have been completed. Acquired hyperbilirubinemia is one of the commonest ones that they can talk about is physiological jaundice. So remember, one point which I want to stress on is physiological jaundice is seen only in 50% of the newborns. Don't think it is seen in all newborns. It is seen only in 50% of the newborns. And when does the bilirubin start rising? Only from the second day of life. So if they give you any case scenario where they say from the first day of life itself bilirubin is elevated, you have to think of congenital hyperbilirubinemias. Here it is the second day of life. So then you have to think about, okay, it must be a case of physiological jaundice. Okay, and usually the bilirubin does not rise more than 15 milligrams per deciliter. And what is the reason for that? Remember, an immature hepatic system of conjugating. That means UDP glucuronide transferase is immature. Liver itself functioning is immature. And then other thing is, because a lot of RBCs were there when it was in utero, these are getting lysed now once they come here. Now oxygen is quite enough here in this atmosphere for that. Whereas in utero, the oxygen was less. That's why they had to produce more RBC. But now when it enters into this real life, here there's plenty of oxygen. So it doesn't require so many RBC. So RBC are getting lysed. So much of lysis is happening that plenty of heme is being degraded to form bilirubin. That is the reason why it has to deal with that much excess of bilirubin. And because conjugation is not proper, therefore you have a lot of unconjugated bilirubin here. So that is something for you to remember. So the scenario here you can see. So because here, let us look at this. Hereditary spherocytosis. So remember, spherocytosis, an abnormal shape of RBC. So RBC rupture, this is a case of hemolytic jaundice. Remember that. Next, another case, if they give you something like this, severe itching in a 55-year-old woman, yellow eyes, dark urine, pale stools, again, dark urine, pale stools, intermittent right upper abdomen, something related to gallstones. So think of gallstones, conjugated hyperbilirubinemia, because stools are pale, urine is dark, itching is there. That means bile salts are also being excreted. So try to remember this. Then this is a scenario if they give you fever is there, nausea is there, loss of appetite. Again, right upper quadrant where you have the liver, yellowish discoloration. You have to immediately think about, okay, must be related to hepatic jaundice. Because there's a nausea, loss of appetite, right upper quadrant, yellowish discoloration. So definitely jaundice. But because there is nausea, loss of appetite, and they've not mentioned anything about pale stools, etc., must be a case of hepatitis. So therefore, hepatic jaundice. So these are the different case scenarios that you might get. Now let us look. So we have completed now porphyrias. We have seen bilirubin abnormal, and then this is just about acid-base disturbances. I have 5 minutes more. So shall I stop here or shall I continue?
Ma'am?
I have 5 minutes more because it's going to be 7, no? I just wanted
It's
to know.
okay, ma'am. It's okay, ma'am. Continue cheyandi, ma'am. Parలేదు, ma'am.
Okay, right.
Okay.
Right. So here, now this is acid-base disorders. I thought I'll just cover that because this is, you can get, it is like maths. You can get full 5 on 5 in this if you diagnose it correctly. Okay. So they might give you a case like this. A 70-year-old man suffering from chronic obstructive pulmonary disease was admitted to the hospital with an acute exacerbation of his illness. His arterial blood gases revealed the following. So diagnose, comment on this. They might tell me what is the acid-base disorder, and then what is the cause of the acid-base disorder, and how did you arrive at your diagnosis. These are the ways that they can ask you the question. So when you look at this, what do you have to, don't directly go immediately into this and say, okay, what have they written about pH, PCO2 and all that? Don't look at this. First, look at what they have asked here in the case. So in the case, they have asked you chronic obstructive pulmonary disease. So that means lungs have been affected. So when the lungs are affected, you have to remember that lungs are related to carbon dioxide. Remember two things at least. Lungs are related to carbon dioxide, bicarbonate related to kidney. Just remember these two. So whenever lungs are related to carbon dioxide, you call it respiratory. Bicarbonate is related to the kidney. So that is usually called as metabolic. So that's why you have two types of acid-base disturbances. One is called metabolic acidosis or alkalosis. One is called respiratory acidosis or alkalosis. Now you are looking here, you now studied that and you said, okay, chronic obstructive pulmonary disease is there. Now let me look at the carbon pH first. So first we look at the pH. Now when you saw the pH, they may or may not give you the reference ranges. So please learn this by heart. It's not very difficult. It is easy to remember. 7.35 to 7.45 is the normal pH. Now just below that you can see carbon dioxide partial pressure. You just remove that 7, you will get the partial pressure of carbon dioxide normal value, 35 to 45 millimeters of mercury. That is how to remember that. Bicarbonate, you please have to by heart this 22 to 26 milliequivalents or millimoles per liter. This is the normal range. Okay, now you looked at the pH and you said, oh, it looks like acidosis. Normally it should have been 7.35. Anything less than 7.35 is called acidosis. Anything more than 7.45 is called alkalosis. Now, what commonly I have seen students doing a mistake is they look at this and say 7 must be our neutral pH and anything less than 7 only we consider it as acidosis. Please, it is not like that. Your blood pH is 7.35. Though it is on the basic side, anything less than that we call it acidosis. Anything more than 7.45, though it is basic, more than that only you will call it alkalosis, because this is considered as the normal pH of the blood. So anything less than 7.35 is acidosis, anything more than 7.45 is alkalosis. Okay, so you have looked at that chronic obstructive pulmonary disease and you are now looking down and saying, okay, it looks like there is acidosis. Let me look at carbon dioxide. Oh, carbon dioxide value is extremely high. So then it must be a case of respiratory acidosis. Then you look down, bicarbonate value. you can see bicarbonate has increased. Normally, bicarbonate, if it is increased, it means alkalosis. But it is showing acidosis. Why did bicarbonate increase? I said bicarbonate is related to the kidney. And you should always know one thing. Whenever there is a respiratory problem, kidney will enter into the arena. What will the kidney do? Kidney will try to bring the pH back to normal. What it is doing is called compensation. It is trying to bring the pH back to normal by increasing the amount of alkali, because carbon dioxide, if it is high, it can form carbonic acid. So now we are unable to breathe out properly. Ventilation has gone. Why has it gone? Because the person is having chronic obstructive pulmonary disease and it has become worse. Acute exacerbation is there. He is unable to breathe out properly. I have seen many students writing that, okay, the person is going to breathe out. He cannot breathe only properly. His ventilation is poor, because of which only PCO2 has increased. So it is a case of respiratory acidosis, and the bicarbonate has increased. Why? As a compensation. How will the bicarbonate increase? Kidney has entered into the arena, and what has kidney done? It has reabsorbed a lot of bicarbonate. More bicarbonate, it is reabsorbed. That is why the bicarbonate is high. So what will you call this? This is called partially compensated respiratory acidosis. If you write this and write one of the causes, whichever you know, chronic obstructive pulmonary disease is one cause. Similarly, you can have, in a case of cardiac arrest, you can have respiratory arrest, you can have this feature. Okay, so remember any cause. Acute asthma, severe acute asthma the person is having, then you can have something like this. Severe emphysema the person is having, you can have a feature like this. Suddenly there is choking, then you can have a feature like this. So just remember this. So look at the case scenario, then look at the values. That is how you will get it. Another case which can come. So the previous one was respiratory acidosis, which was compensated, right? And it is compensated by what? By the action of the kidney, which is reabsorbed. Now look at this second case. 45-year-old man was admitted with a history of persistent vomiting. So he had a long history of dyspepsia. Dyspepsia means indigestion. On examination, he was dehydrated, respiration is shallow. Analysis of ABG showed the following. So here, what can you see now? Don't directly again go into the what are the values given. Look at the case. Case is saying persistent vomiting. So when you are vomiting out so much, what is being lost? Acid of HCl is being lost. When acid is being lost, what is there? One thing that you have to remember is every time an acid H+ is being produced, the body will produce again HCO3 into the blood. So every time he is vomiting out and HCl, new HCl has to get formed, lot of bicarbonate is being produced within the body. So he is having a case of alkalosis. So now then you look down, look at the pH. Yes, it is showing alkalosis. Then you look at the bicarbonate. Is it showing alkalosis? Definitely it is more. So it is alkalosis. Now, why is the carbon dioxide level increasing? This is increasing because now the body, what is it trying to do? It has to get the pH back to normal. There is so much of alkali. So what should it do? It should reduce the respiration. That is why it is mentioned here. Respiration is shallow. That means this is a case of hypoventilation. So when there is hypoventilation, you are now holding up a lot of this carbon dioxide. So when you are holding carbon dioxide, what is happening? You're having more of carbonic acid being produced. So alkali is increased, along with that acid is also increased. It is trying to bring the pH back to normal. So that is one thing. And remember the cases of alkalosis, one of which is given here, vomiting, you have alkalosis. Then you have alkalosis if you are having a condition called Cushing's disease, you can have alkalosis. Or for some reason, IV bicarbonate is given to the person, you can have alkalosis. Now, another case, as you can see, an 80-year-old female, pneumonia has been mentioned and fever. So when pneumonia, lungs. So when lungs are affected, immediately look, oh, pH is low, carbon dioxide is elevated, okay? Bicarbonate is still normal here. Bicarbonate has not gone out and they've given oxygen, saturation, etc. So just look at the first three values. So here you can see that it is pneumonia, lungs are affected, acidosis is there, carbon dioxide. Whenever carbon dioxide is elevated and acidosis, you know it is respiratory acidosis. Is there any compensation? No. If compensation should have been there, bicarbonate should also have been increased. That is not there. So therefore, this is not a case of partial compensation. It is uncompensated respiratory acidosis. Okay. Another case which can come. So here they have mentioned a 32-year-old man who's depressed, alcohol abuse is there, altered mental status. And what have they given in ABG? Look at the pH, which is very low. You look at the PCO2, that is also low. Oxygen has been given. Then they have also given sodium, chloride, and bicarbonate. You get bicarbonate extremely low. So whenever you get such a type of bicarbonate, you should know that if bicarbonate is very low, I hope you remember the Henderson-Hasselbalch equation, where always for a bicarbonate buffer, if you remember the equation, you know it is base by acid, right? What is the Henderson-Hasselbalch equation? pH is equal to pKa plus log of base by acid. So the base is bicarbonate for a bicarbonate buffer. The acid is carbonic acid, right? Here you can see the base is so low. If the base is so low, naturally compared to that, the acid is high, right? Carbonic acid is high. So we call it a case of metabolic. I said anything to do with bicarbonate, you call it metabolic. Metabolic acidosis, because pH is low, bicarbonate is low, so it is acidosis. Then why is it that carbon dioxide has also become low? What will happen when you have metabolic acidosis? Because the bicarbonate is low, now what should the body do? It should remove that carbonic acid also. How will it remove carbonic acid? Only through hyperventilation. So the person has gone into hyperventilation, because of which you can see PCO2, which should have been 35 to 45 millimeters, has come down to 29. So that means there is hyperventilation involved. What is the reason you think? Because alcohol abuse, when it is there, so you are having a lot of acid. Gluconeogenesis, you know, it is going to get inhibited, right? So when gluconeogenesis is getting inhibited, a lot of lactate is being produced now. That lactic acid which is there in excess, that is causing the metabolic acidosis. It is causing metabolic acidosis. Now there is something here which also is there. So not only is it partially compensated metabolic acidosis, you also have to know something called an anion gap. Some people are asking that question. So as you all know, there are these three tissues which are controlling. One is the blood buffer, which acts immediately. You have the respiratory regulation, you have the renal regulation. So whenever there is a respiratory problem, the kidney will come to help. Whenever there is a metabolic problem, too much of acid or base is there, immediately the respiratory will come into action. This is something that you have to remember. So whenever you assess ABG, just remember these are the normal values. So try to remember the normal values. pH and PCO2, I think now I have told you all, it is easy to remember. Bicarbonate, remember this value. Oxygen and the partial pressure of arterial oxygen or oxygen saturation usually will not be asked. So interpretation, start off with, is the pH normal or acidic or alkaline? Then you look at the partial pressure of carbon dioxide. If it is less than 35, we call it respiratory alkalosis. More than 45, we call it respiratory acidosis. Or it can also be a part of that whenever there is compensation. Okay. Then you look at the metabolic indicators, which is bicarbonate. If it is less than 22 bicarbonate, it is acidosis. More than 26, we call it alkalosis. Then you look at whether it is uncompensated, partially compensated, or fully compensated. Usually it will not be fully compensated. Either you get an uncompensated or a partly compensated. What do we mean by uncompensated? pH will be abnormal, and one of the two only will be abnormal, either carbon dioxide or bicarbonate. One of them only will be abnormal. The other will be normal. Okay. Then this is just to show you so that you understand here. So you can see that it is alkalosis, and you can see what is causing the alkalosis. Here it is bicarbonate. What about carbonic acid? It is normal. This is normal value. Okay. So what type of compensation? It is uncompensated, because one is abnormal, the other is normal. So therefore, this is called an uncompensated metabolic alkalosis. Then what is partly compensated? pH is not normal. Carbon dioxide is also not normal. Bicarbonate is also not normal. Okay. So if this is the way it is, then it is called partly compensated. And these causes, please remember, metabolic acidosis like diabetic ketoacidosis, lactic acidosis, renal failure, diarrhea. So when you are having diarrhea, what will happen? A lot of alkali goes away. from the body. If alkali goes away, then what is going to happen? What is left in the body now? A lot of acid is left. Okay, or there is a condition called renal tubular acidosis where the kidney tubules lose bicarbonate. That is also one condition. Respiratory, I told you, anything to do with lungs or the entire airways. Metabolic alkalosis, severe vomiting, okay, IV administration of bicarbonate. Hypokalemia, which is seen in some conditions, that is potassium is low, it will usually cause alkalosis. Nasogastric suction, when you're removing a lot of fluids from the stomach. Respiratory alkalosis, remember this is hyperventilation. When the person is breathing, ventilating too much, like an anxiety, anemia, fever, etc. Salicylate poisoning, then you will have this respiratory alkalosis can be seen. I told you an anion gap. So what is this anion gap? So the simple definition for this is, if you take the total measured cations minus measured anions, whatever is left is called the anion gap, because we know that the body has to maintain electrical neutrality. Electrical neutrality means what? How many cations you should have, so many anions you should have. So, but measurable cations are sodium and potassium. What you can measure, that is in the laboratory, what all you can measure are sodium and potassium. We also measure chloride and bicarbonate. What is not measured is there are some anions which cannot be measured, and that is the gap. We call it as the anion gap. How do you calculate it? Sodium plus potassium minus chloride plus bicarbonate. So if you take that, usually it should be 8 to 18 milliequivalents per liter. Some have even given it as 8 to 12. So it is up to you. Looking at your textbook, you follow that. So it tells you about unmeasured anions. Then there is a type of metabolic acidosis where you have what is known as a high anion gap or increased anion gap. What is this increased anion gap? Increased anion gap is like we have seen in that case of alcohol abuse. We have seen that the bicarbonate was extremely low. So here also the bicarbonate is very low. What could be the reason? It could be some ketoacidosis, diabetic ketoacidosis. It could be lactic acidosis. So these acids, what have they done? They have used up the bicarbonate. So the bicarbonate is gone, and the anions of these acids, like lactic acid, what is its anion? If it gives off its H+, it forms lactate. Similarly, acetoacetic acid, which is a ketone body, if it gives off its proton, H+ ion, what is left? Its anion is left, which is acetoacetate. So that is what is going to, so those are going to increase, and they are not measured. So therefore, that anion gap, because it has eaten up the bicarbonate and its level has increased. So when you do sodium plus potassium minus chloride plus bicarbonate, you will get a very high value. So you will get a value more than 8 to 18. Here you can see that the value is 25. So this is a case of high anion gap. So similarly, why I wanted to talk to you about this is, usually they might also ask you, calculate the anion gap in this patient. Like when we go back to that case that we have seen. So in this case, if you want to calculate the anion gap, they have only given sodium here. So you need not worry, because sodium is the major cation. Even if they don't give potassium, it is okay. So what you have to do is 140 minus chloride is 101 plus bicarbonate is 5, that is 106. So if you do this 140 minus 106, you'll get quite a lot, big value. Now definitely it is more than 8 to 18. So then this is a case of high anion gap metabolic acidosis. What has caused the metabolic acidosis? Probably lactic acid increase, because there was a case of alcohol abuse here. So that is what you have to remember about high anion gap. So just like you have high anion gap, you also have something called a normal anion gap. Normal anion gap is what? It is, though the bicarbonate is low, what the body has done now, it is trying to reabsorb more chloride. So it has increased the amount of chloride absorption. So when it has increased the amount of chloride reabsorption, what happens is it is going to make up for the loss of bicarbonate. So this is called normal anion gap. So therefore the anion gap here also, look at this, it is 15. Here also the normal person, it is 15 only. So that's why this is called a normal anion gap. So let us look at when will we have a high anion gap, when will we have a normal anion gap. High anion gap, just remember, whenever you have ketoacidosis or lactic acidosis, in that you will usually have a high anion. The others are if you want to know about it, but at least remember these two, ketoacidosis and lactic acidosis. Remember that. Next, normal anion gap, remember these two. One is diarrhea. So when a person is having severe diarrhea, so alkali is going out, because we know that the pancreatic secretion is full of bicarbonates. All the alkali is going out. So what will the body do? It will reabsorb more and more. It will reabsorb the chloride. So chloride level is high. In renal tubular acidosis also, the tubules are losing bicarbonate. So they will reabsorb more and more chloride. So this will cause normal anion gap metabolic acidosis. Okay. So with this, we have completed acid-base important questions we have completed. Now let us look at amino acid metabolism. Finally, we have come to amino acid metabolism. So in this, a case might be given to you like this. What is this case now? This case, they are talking about 24 hours after birth, a formula-fed, right, 24 hours after birth, a formula-fed male infant. So look at this, it is written male. Whenever it is male, it is giving you some hint, especially related to urea cycle. Becomes somnolent, feeds poorly, begins to vomit, goes into coma, looks like sepsis, but there are no risk factors. Sepsis workup is negative. Serum ammonia is elevated. Ornithine is elevated. Citrulline is undetectable. That is a hint they have already given you. Citrulline is not detectable. Ammonia is elevated. Ornithine is elevated. Okay. The maternal grandmother tells you that she has a son who died as a baby from there. Which of the following enzyme is defective? So here now you can see that ornithine is elevated and citrulline levels are not detectable. So it could be, is it carbamoyl phosphate synthetase? Is it ornithine transcarbamylase? So, or is it arginase? Is it alanine aminotransferase? Is it pyruvate carboxylase? So simply you can rule out pyruvate carboxylase easily because it will never enter into this cycle at all. You can rule out ALT, alanine aminotransferase, you can rule it out. Now, arginase, these are the three enzymes which are related to it. So you can rule out arginase because arginase, if that is there, that means the previous enzymes were all there. Arginase is the only one which is not there. So much of ammonia will not be formed. So much of excess ammonia will not be formed. So you can rule out arginase also. Then you have a doubt about carbamoyl phosphate synthetase and ornithine transcarbamylase. So here they have given you ornithine is elevated. Okay. And sometimes they might also give you homocitrulline is produced. They might give you. Okay. So and they have given male. Whenever it is male, think of ornithine transcarbamylase, especially when serum ammonia is high and citrulline levels are undetectable. That means citrulline is not being formed. If citrulline is not being formed, what was the problem then? Carbamoyl phosphate probably is formed. It is able to, it should have been binding to ornithine so that you will get in the next step a citrulline formation. So though carbamoyl phosphate is there, it is unable to bind to ornithine because ornithine transcarbamylase is not there. Because it is not there, the citrulline level is low. So it is a case of ornithine transcarbamylase deficiency. Then they can ask you in detail about why hyperammonemia, etc. So this is something that you can remember. So as just a fast recap of this pathway, I think all of you are very thorough with this pathway, so I'll just go about it fast. So here also you have two compartments. One is the mitochondria, one is the cytosol. Where is it taking place? In the liver, in the liver. Always remember that clearly. First write the organ, then write about the compartments. So in the liver, how many enzymes you are having? You are having 2 enzymes in the liver and the rest of the enzymes are there in the cytoplasm. Okay, so 2 enzymes in the liver, 3 enzymes in the cytoplasm. What are those 2 enzymes in the liver? You can see the first one, carbamoyl phosphate synthase 1. And you are having ornithine transcarbamylase. So in carbamoyl phosphate synthase 1, what has happened? The carbon dioxide which is there, that it becomes bicarbonate. The ammonium which has formed, how did this come? From glutamate dehydrogenase. That was the enzyme which removed ammonia from glutamate. So it has come out as ammonium ion. With the help of energy, because this is a synthetase. Because it is a synthetase and it is synthetase 1, that means there must be a synthetase 2. Now that synthetase 2 will come in pyrimidine synthesis. This is coming in the amino acid metabolism, that is in urea cycle, this is coming. So carbamoyl phosphate synthetase 1, this is in the mitochondria, and because it is a synthetase, we are utilizing 2-ATP. What is the product which is formed? Carbamoyl phosphate is being formed. This carbamoyl phosphate will bind to ornithine in the presence of ornithine transcarbamylase and form citrulline. In the case which we saw, citrulline was low. It indicates that this enzyme is defective. Okay, now for a normal person, citrulline has been produced. Now citrulline will go out through its transporter so that it enters the cytoplasm, and the cytoplasm, it joins with aspartic acid, which is a non-essential amino acid. It will join with that. Here also remember, it is not a synthase but a synthetase. Because it is an argininosuccinate synthetase, here also it requires ATP. But ATP is converted into AMP here, right? So it is equivalent to 2 ATP. Energy of 2 high energy bonds are used, so equivalent to 2 ATP. So here you can see 2 ATP, here also 2 ATPs have been used, right? So what is the compound formed? Argininosuccinate is formed. Then you have a lyase which is acting, arginosuccinate lyase. In some books you'll see it as arginosuccinase, and fumarate is released, and you have arginine being formed. Then the last enzyme is arginase, where you have ornithine forming and urea forming. So ornithine which has come out, so it has entered the cycle, it has come out. It is acting like a catalyst only, similar to oxaloacetate in the TCA cycle. It enters the cycle, comes out of the cycle. Here also ornithine enters the cycle, comes out of the cycle. So remember, 5 enzymes, 2 in the mitochondria, 3 in the cytosol. How much energy has been used? Here 2 ATP, here 2 ATP. But because fumarate is there, and fumarate now goes into the TCA cycle, and there you can see that in its reaction, fumarate is going to get converted. So in that reaction, so there what is happening, it will again utilize some amount of ATP, it will utilize. So overall, you can also write overall so many ATPs also you can write. Otherwise, you can just write 4 ATP. There is no problem in writing and leaving it rather than explaining this bicycle pathway. Okay. Then we come to the next one. This is just to show you in detail. So this is so that you will get an idea from where this ammonia is coming. It is coming through glutamate dehydrogenase, to get that idea. And also you can see here that ATP is being converted to AMP. This is arginosuccinate synthetase. So remember, don't write it as a synthase, write it as a synthetase. Synthetases belong to the class of ligases. Okay, so that you have to remember. And I told you here, fumarate will finally get converted into malate, and malate is going to cause form oxaloacetate. So NADH is being produced. NADH will give you 2.5 ATP. So 4 minus 2.5. So you can calculate it like that also and say that, okay, overall how many ATP have come. Okay. Then hyperammonemias, when you have to write a list, write about the enzymes and say that, okay, hyperammonia, these are the things where ammonia level is increased. Remember, for the enzyme deficiencies of the later phases, that is from arginosuccinate synthetase, then you have arginosuccinase, arginase, all of them, because previously you have some products which are able to bind to that ammonia. So therefore, hyperammonemia will be not so much. For the first and the second only, there will be plenty of ammonia. That is why they're usually written as hyperammonemia type 1, type 2. That is what is written, because hyperammonemia will be more. Ammonia levels will be more. That's why they write it like that. And what is the treatment? If you have CPS1 deficiency, the treatment will be for hyperammonemia, benzoic acid, which is given as benzoate or phenylacetate. Benzoic acid will bind to glycine and form hippuric acid. Phenylacetate will bind to glutamine and form phenylacetylglutamine. What is the purpose of that? Because all the ammonia has to be now used to form glycine. When glycine is removed as hippuric acid, you require more amount of ammonia. So at least ammonia will enter into that pathway to produce glycine. So that is the reason why benzoic acid is given. Similarly, to form glutamine, we require glutamate to be formed. And through glutamate, again, ammonia should be added so that you get glutamine. So that is another reason why if glutamine is excreted as phenylacetylglutamine, then you will require more amount of ammonia to be entering into this pathway so that you will not have a high level of. So whenever they give you a question on ammonia, talking to you about ammonia, hyperammonemias, please do not write about uremia. Okay, write about hyperammonemia. If they are clearly telling you uremia, that means urea levels are high. When they tell you hyperammonemia, you don't have to write about urea at all. Look at the question carefully, what they are asking you, you only answer to that. That is about urea cycle disorders. Then we come to glycine. So glycine, what I want you to know here is the important products derived from glycine. I have seen some students writing about they form protein, serine, glucose. These are not important products. Okay, these are not considered important products. Now, what are the important products? The important products are purine. It will form the certain atoms in a purine ring. So you have 4, 5, 7 being formed from the purine ring. 4, 5, 7 atoms of the purine ring. It can form glutathione, gamma glutamyl cystinyl glycine. So it helps in formation of glutathione. Heme synthesis we spoke about. We spoke about creatine. We didn't speak about that. So creatine also it can form. So here you have guanidoacetate, to that methylation happens, and finally creatine is produced. Okay, then formal THF, tetrahydrofolate, also you can have through glycine because it's a part of that one carbon metabolism. So from that you can get formal tetrahydrofolate. So remember, these are the important products derived from that. So this is a question you may expect. What are the important products derived from glycine? Then you have to, and I'm telling it to you in brief, you draw the structure also, showing them that where in the purine ring it is forming, what are the 3 amino acids which are required in glutathione, and how glycine is useful for that. And then another point here which is there is conjugation. Conjugation is glycine plus choline, because it is conjugating with the bile acid, so that you are going to have a conjugated bile acid. So glycocholic acid, glycoquinodeoxycholic acid. So that is one. Heme synthesis, show them the first step of the heme synthesis pathway. Creatine, show how it is arginine gives its guanidine group, guanidoacetate is produced. Okay, then after guanidoacetate, then methylation happens. That is how you get this. So you can show that to glycine, when guanidine group of the arginine is being given to it, then it forms guanidoacetate. To that, methylation happens and creatine is produced. So you can mention this also. And another common question they may ask is about disease which is called primary hyperoxaluria. So primary hyperoxaluria will come in glycine metabolism. When you have a deficiency of the enzyme called transaminase of glycine, and you are going to have plenty of formic acid and oxalic acid being formed. If the pathway from glycine to oxalic acid is active, then what is going to happen is continuously oxalic acid will be produced. So that is why the person may suffer from oxalic acid stones. Primary hyperoxaluria can be there. Reason for that is what? Because the transaminase was defective. If the transaminase is defective, they have found out that this transaminase is found in the mitochondria rather than being in the peroxisomes. It is found in the mitochondria. So that is about glycine metabolism. Then the favorite question of many examiners related to aromatic amino acids. So you can see that in aromatic amino acids, so remember 3. Aromatic means they should be having definitely the benzene ring. So remember that. So aromatic amino acids are what? Phenylalanine, tyrosine, tryptophan. And out of these, phenylalanine and tryptophan are essential amino acids. And tyrosine, which is coming from phenylalanine, is a non-essential amino acid because it can be synthesized in the body. So therefore, it is non-essential. Now, what is the reaction? Now, this reaction you have to remember very well. Phenylalanine, in the presence of phenylalanine hydroxylase, is getting converted into tyrosine. For that, what is required? Tetrahydrobiopterin is required for that. So tetrahydrobiopterin in the presence of oxygen, which converts phenylalanine to tyrosine. You don't have to remember the structures. At least you draw phenylalanine and tyrosine and say this is the enzyme which is required to form tyrosine. If this enzyme is deficient, then what are you going to get? You will get a disease which is called phenylketonuria. Now, why is it called phenylketonuria? That is what you can see here. So, right. So you can see that this phenylalanine, if it is not able to get converted into the next phase, it is not able to get converted into tyrosine, you have a transaminase which can convert phenylalanine into phenyl pyruvate. Now, phenyl pyruvate means it is a keto group. That is the one which is excreted. So we call it what? Phenylketonuria. Right? Phenyl pyruvate can be reduced to lactate, or it can be decarboxylated to acetate. And this is the one which is giving you that mousy odor. The specialty is mousy odor. Then it can get conjugated to glutamine and form phenylacetylglutamine. So this is, you have to show this saying that phenylalanine will enter alternate pathways, form phenyl pyruvate on transamination. Now this phenyl pyruvate, that is because it is produced, this is called phenylketonuria. Okay, and then you have to say that phenyl acetate is the cause of mousy odor. Then we come to so this is about this. Now I hope you understand, if they give you a case where they say there is a fair baby which is there, which is mentally retarded baby. So why is this baby fair? Because we know that tyrosine, if it is produced, it can produce actually melanin. But if tyrosine itself is not being produced, no melanin synthesis will be there. So the baby is fair. Okay, and this is an essential amino acid. This essential amino acid is being converted into a non-essential amino acid. And this inhibition is happening here. That is, a deficiency of this enzyme is there. So tyrosine is not being produced. Then why is there mental retardation? Because phenylalanine, because it is a heavy molecule, it prevents the entry of other important substances like tryptophan, etc. into the brain. It will prevent the entry of other essential amino acids like the branch chain also into the brain, and it may cause mental retardation because of that. So that is the cause of mental retardation. Then the other things I'm not going to talk about here, except another one, which is alkaptonuria, which can come as a case. Now, alkaptonuria, how they ask is, the child is having black diapers, or it's passing urine, the color of which is black in color, coke colored urine. Then you have to remember that the enzyme which is deficient is homogentisate oxidase. This is the one which is deficient, which can also be called as 1,2-dioxygenase. If it is deficient, homogentisic acid levels will be high. If homogentisic acid levels are high, that will get converted by a polyphenol oxidase into some alkapton bodies. Okay, so it can form alkapton bodies which can get deposited. Where will they get deposited? It can get deposited in the cartilages. As a person grows older, in cartilages it can get deposited in the intervertebral disc, and it can cause ochronosis. This is a rigidity. They are unable to bend. They will have osteoarthritis of these bones. So that is one question which you can expect. Then tyrosinemia type 1, type 2. These are the things that you just have to remember, the enzyme deficiencies, and they may cause these different tyrosinemias. This may come as an MCQ question, but guarantee for you is this phenylketonuria and alkaptonuria. Okay, this is just to show you about ochronosis. You can see that the intervertebral disc might get affected, and the urine color which is black. And the baby which is fair here, you can see a fair colored child for this mother. Then you know that this must be a case of albinism. If they mention that a fair child is born without talking to you about any other disease, then they just mention that there is a fair child which is there, born to parents who are colored, then you know that it must be a case of albinism. So if it is a case of albinism, then what is the deficiency? Remember, this is the enzyme that is deficient. Tyrosinase is the enzyme which is deficient, which is the one which is causing melanin production. You don't have to remember all these leukodopa, chrome, etc. Tyrosinase, remember this one enzyme. So tyrosinase is deficient. So therefore, this tyrosine is not being converted into melanins. Then the other one they can ask is Parkinson's disease. So in Parkinson's disease, you should know that, okay, dopamine is deficient, therefore they have got. This is just to show you that even actress Jamuna also has suffered from Parkinson's disease. So this is the catecholamines that you can see here. So catecholamines, how are they produced? What are the catecholamines? Which have a catechol nucleus. This is called the catechol nucleus. So if they have the catechol nucleus, they are called catecholamines. So here you have tyrosine, which is being converted into DOPA. What is the enzyme? You can see here it is a hydroxylase. Here also it requires tetrahydrobiopterin. Remember, the same thing came in phenylalanine hydroxylase also, and it will also come in tryptophan hydroxylase also. Okay, and the coenzymes always for all these three are tetrahydrobiopterin. It forms DOPA. DOPA, when you have a decarboxylation, remember always it is PLP. Dopamine is produced. Now dopamine is again undergoing hydroxylation. This hydroxylation, you have vitamin C, which is required for it. And you have the formation of norepinephrine. Norepinephrine will get methylated to form epinephrine. So it is called NOR. That means it is not methylated. Epinephrine, which is methylated. So these are the three catecholamines: dopamine, norepinephrine, and epinephrine, which have been produced. So if you have a deficiency of dopamine, that means this person will have a disease which is called Parkinson's disease. Then we have metabolism of branch chain, MSUD. This is another question where they might say that the smell of urine is of burnt sugar smell is there. Then you have to remember that these are the three essential branched chain amino acids whose metabolism is disrupted. How is it disrupted? These are the branch chain amino acids. They undergo transamination to form the keto acids. These keto acids are acted upon by this enzyme, which is called keto acid dehydrogenase. And this enzyme is important because this enzyme is similar in action to PDH complex. Okay, so PDH complex also, you have a similar enzyme which also, excuse me, acts like this. Right? So you have the formation of these keto acids. Just a minute. So we have the formation of these keto acids. So when these keto acids are formed, if this enzyme is going to be deficient, then you will have a lot of keto acids being produced. And these children will also have mental retardation, right? So that is one point to remember. Deficiency of this enzyme, you have increased keto acids, and that will cause mental retardation. And finally, we come to the sulfur-containing amino acids. Sulfur-containing amino acids, you should remember that methionine, which is an essential amino acid, and cysteine, which is a non-essential amino acid. So for this, methionine is converted to homocysteine. Homocysteine is being converted into cystathionine. So it has to bind to serine to form cystathionine. If this enzyme is deficient, then you have homocysteinemia. What is the danger of this? The danger of this is, if you have high homocysteine, it might also cause thrombosis. It can cause myocardial infarction. And it can also cause lens dislocation. Okay? And a marfanoid habitus, that means the person will appear very tall and a very large person. That is how this person will appear. And this cycle where you have a regeneration of methionine, you should remember this cycle also came when you learned about the folate trap. So remember that cycle and this cycle, try to remember these two. So you're having methionine. Methionine is being converted into SAM. SAM is being converted into S-adenosyl methionine through a methyl transferase. You have a methylated acceptor, which is forming methylated products. Sorry. And finally, you have here that hydrolase will act and release homocysteine and adenosine. Homocysteine is again converted with the help of tetrahydrofolate and B12, again back to methionine. So whenever you have anything which prevents homocysteine being converted to methionine, that will also cause homocysteinuria. Okay. So with this, hopefully we have covered quite a lot of portion. If anyone wants to ask anything.
So, thank you, ma'am. Let us conclude today's session with Shanti Mantram. Om Sarve Bhavantu Sukhinah Sarve Santu Niramaya Sarve Bhadrani Pashyantu Ma Kaschid Dukkha Bhave. Om Shanti Shanti Shanti. As we conclude today's session, I extend my heartfelt gratitude to Dr. Vijaylakshmi ma'am for her insightful and enriching session. Thank you, ma'am, for your valuable time, guidance, and unwavering support. We also thank all the participants for their enthusiastic presence and active participation.
I think some chat. Okay, only. Thank you so much, you said. I thought some questions will come. Okay. Then.
Yeah, ma'am.
Right,
Thank you, ma'am.
Yeah.
Thank you, ma'am.